Hello, I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine, and it's a pleasure for me to have two fabulous faculty members, one from Georgetown and one from Johns Hopkins as well, for this GRACE discussion. And it's a pleasure for us to have a forum where we can discuss cases and work through how we would manage these cases. And so we'll be doing that over the next 30 to 45 minutes. We'll be looking over separate cases and talking about how we would manage these, and maybe even taking a step back and talking about some of the treatment or diagnostic implications of these cases. But before we get started, I just want to turn it over and have each of the panelists introduce themselves before we get to the cases. So Stephen, I'll start with you.
Thanks, Ben. Happy to be here. My name is Stephen Liu. I'm a medical oncologist at Georgetown University in Washington, D.C.
And Julie?
Hi, thanks for having me. I'm Dr. Julie Brahmer. I'm a medical oncologist at Johns Hopkins.
It's great. Pleasure to have you both here. And again, we'll try to get to 3 or 4 cases. And these are real cases. So I think the relevance here will resonate with all of us. So we'll start with patient 1 here. This is a 48-year-old male. He's a hedge fund manager. He's married. He's a never smoker, and has 2 siblings and no history of any malignancies. His past medical history is consistent with hypertension and hyperthyroidism. His surgical history is just significant for wisdom tooth extraction. And he has no allergies, only on synthroid and hydrochlorothiazide. And his initial presentation to us was in March of 2018, when he presented to the emergency room with worsening shortness of breath and cough and a 10-pound weight loss. His examination showed decreased breath sounds bilaterally. He did have a right supraclavicular node, or a nodal enlargement above his right clavicle, which was palpable, so we could feel it. And a CT scan in the ER demonstrated what we see here. And what we're seeing here is a cut of the lungs, and we can see here on the left image a mass roughly 2 centimeters in the right upper lobe. That's that white spiculated spot there. But then when we see across both lungs in other cuts, we see a lot of white here. And that white is really disseminated lung cancer across both lungs. Clearly this patient has lung cancer not only in his right lung, but his left lung as well. The patient does get some initial blood work that's not, that abnormal. He has a slight anemia or low red blood cell count, and he's admitted to the hospital for management. He's placed on oxygen. And as part of all of our lung cancer workups, the presumed lung cancer workups, he does get an MRI of the brain. We need to be mindful that lung cancer can go to the brain, and he does get an MRI of the brain that is negative. His patient, we often have to decide what's the best way to get tissue on patients. And maybe this will be my first stopping point to ask the panelists, so this decision on where to get tissue and how to get tissue. I think we now know that tissue is critical, and we can talk about other ways that we get information for lung cancer patients, not just off tissue, but potentially liquid or blood. But maybe I'll start with Stephen. Some of the considerations you have when you see a patient like this, and some of your thought processes on, what's the best way to get tissue? And is there a thought process? And is this a discussion you have with your multidisciplinary team?
It really is. And I think that's changed a lot during our careers. In the past, I think a lot of oncologists wouldn't be called until the diagnosis was already established. but we are encouraging our colleagues, our internists, our referring doctors to really involve us pretty early if there's a suspicion, because how and what you biopsy makes a big difference. I think in the past, you wanted to make a diagnosis, and a diagnosis of cancer is made with a biopsy. We'll talk a bit about liquid biopsy during these sessions, but today, to make a diagnosis of cancer, we need a tissue biopsy, a needle biopsy, a surgical biopsy, to really look under the microscope and establish that this is indeed cancer. And I think we've all been fooled where we saw something that really looked like a cancer, but ended up being an inflammatory lesion, sarcoidosis, infection, something different. We need to prove that it is a cancer. And we used to do that in the safest possible way, the smallest needle, the most accessible lesion, to really minimize any risk from that biopsy. Now, though, we realize that what you biopsy and how much tissue you get from that biopsy can have major implications on the treatment course. Lung cancer really is managed by molecular testing. We have to keep that in mind when we do this biopsy, that making a diagnosis of carcinoma or lung cancer or non-small cell lung cancer, even adenocarcinoma, that is not enough of a diagnosis. That does not give us enough information. We need more tissue. So we want to biopsy an area that will yield enough tissue to do the types of tests we need. Lymph nodes, lung organs, those are all lesions that can be biopsied. Bone can be biopsied, but when we decalcify the bone for the processing, that can sometimes damage the DNA and make subsequent molecular testing a little more difficult. And I'll end with one more thing. We still want to minimize the number of procedures. So if I have a suspicious lesion outside of the chest, if I can make the diagnosis and establish the stage of that cancer in one process and one procedure, then I'd prefer to do that.
Yeah, it's well stated. I think encapsulates all the things that I think we think about when we see these patients. Julie, do you talk, if you see these patients, are you talking to both the interventional pulmonologist and the interventional radiologist? Who's making the decision? Is it the medical oncologist here? Stephen talked about how important it is and how critical it is to get tissue. Who makes this decision for you? Or is it who makes the decision? Your team? Is it you? Is it your colleagues? How's this done?
Yeah, I think that to Stephen's point, the tissue is really needed when we want to look at PDL1 as well as the diagnosis. And thus far, blood has not yet been great about picking up PDL1 expression on tumor cells, but I'm sure that's coming. But from a diagnosis standpoint, to decide where to biopsy, a lot depends on who's ordering that biopsy. So it potentially could be an internist, it could be a pulmonologist, it could be the floor team. And that's who ends up deciding. Obviously, it's great to be involved early on to best decide where the biopsy is done in order to be able to get the largest amount of tissue safely, as well as establish stage if needed.
Yeah. So this patient, a lot of the things that you guys so eloquently stated, the conversations did go down, and I think in a never smoker, and we now know that 20% of lung cancer is never smokers, and this is something we're seeing more commonly. The need for tissue is important. We can talk about why that is. This patient had a CT-guided biopsy of that big node on top of his clavicle, and it did reveal the most common type of lung cancer was non-small cell lung cancer. And the subtype that we see, which is about 70 to 75, 80% of non-small cell, was adenocarcinoma. As you mentioned, Stephen and Julie, this tissue was sent off for molecular testing, otherwise known as NGS or next generation sequencing. So we all know that may take some time, and maybe we can talk about the importance of that in a few slides down. But clearly, all the right steps were put in here, and we got enough tissue. The PDL1 was 80%. Remember, we do try to capture both what type of lung cancer it is, but also additionally, two separate things. PDL1, which is important to drive immunotherapy decisions, but also more importantly, potentially, is molecular testing and next generation sequencing. And that takes a little more time sometimes than the PDL1. So this is what we have right now. We have a patient, you saw the scan, the patient's a little bit symptomatic. The patient has a biopsy, and the patient, sent sent out on 4 liters of oxygen. And I guess the question is what should be done next for this patient? And I don't know if there's a right answer here. We have a patient with lung cancer in both lungs with an adenocarcinoma diagnoses. We have the PDL1 back. The patient's a little bit symptomatic, and we don't know yet about the molecular testing, which we know can drive treatment decisions. So, Stephen, no right answer here, but what would you do in this setting in a patient like this?
Well, you mentioned that he was stabilized, was sent home. I will sort of also in the same breath mention that this person is fairly, I think, symptomatic. He's on oxygen now. He wasn't before. And when I see CT scans like that, and I think we've all seen our share, it gets my attention. There's a lot of disease there. And in someone who's already hypoxic, I think a little more progression and this person can really be in trouble. So this is not an elective process. And this is a workup that needs to go fairly quickly. This person needs to start treatment pretty soon. And so I think that our next steps really need to be figuring out what treatment we need and sort of what the optimal sequence of therapy is.
Right. So a good framework to start. Julie, I'll put you on the spot here. So Stephen said maybe starting treatment. What would you start with? Would you start with chemotherapy? Would you start with immunotherapy? We know the PDL1 is 80%, and we've learned from you that PDL1 greater than 50%, those patients derive a meaningful benefit with immunotherapy. So this is a patient that may need treatment. We know the next generation sequencing, the molecular testing may take 2 to 4 weeks to come back to tailor that treatment. What would you do in this case?
Well, I think this
Right
is
answer, by the way.
a great case. I think at this point, while we're waiting, I would order an additional test to be drawn, doing cell-free DNA or ctDNA in the blood to see if we can, by chance, pick up tumor DNA circulating in the blood. This is not tumor cells, but DNA that's shed in the blood. And the hope is that the data would come back more quickly compared to the tissue NGS in order to be able to direct therapy. But I agree with Stephen. I don't know if I'd feel comfortable waiting at all for treatment. Now, with this patient who's a never smoker, you're tempted with a high PDL1 to do pembrolizumab, but the fact that he's a never smoker gives me pause in the fact that there is a fair chance that this gentleman would have a targetable gene change that we can use a pill for. And if we give them, or these type of patients, pembrolizumab first, and then try to give a targeted therapy, there's a higher chance of side effects. So honestly, I may start, if for some reason I'm worried that I can't do a cell-free DNA test for some reason or another, I would consider giving them just chemotherapy first while I'm waiting for the NGS. So that's
all right. You both are right. So this patient got chemotherapy, and at the same time, prior to chemotherapy, we ordered a liquid biopsy. And Stephen, maybe you can talk just briefly about liquid biopsies and why we're using them, and this whole idea of capturing 10 cc's off of a patient or 10 cc's of blood off a patient that may allow us to decide which treatment. Sounds like science fiction 10 years ago, but it's reality for our clinic patients now. Briefly, just a bit on liquid biopsies.
We know when tumor cells die, they break and release their DNA into the bloodstream. And we have now the technology to capture that DNA and to look for cancer-associated mutations. These tests are commercially often done, and there are several different vendors out there. The turnaround has gotten better and better. And I think that years ago, it took a couple of weeks. Now we will often have those results back within a week. And a lot of times we'll get the results back before we can even schedule our next dose of chemotherapy. So they can come back quite quickly, but it's important to interpret them in the right way. They are fairly specific, meaning if we do a blood test and we find an actionable driver mutation, we see this change that we can target, we believe it, we act on it, we move. If we, however, get nothing back, there could still be something there. It's not always picked up in the blood. Some tumors are not shedders, meaning they don't release their DNA. And so you may miss a lot of them. If you see a positive test, we believe it. If you see a negative test, you have to wait for the tissue.
Yeah, I think it's been a pleasure to see the advancements in this happen so quickly. It's been such a win for our patient. Julie, Stephen talked about actionable mutations, and maybe we can just step back like 10 steps here. What are actionable mutations, and why is it so important to order these liquid biopsies? I mean, what's this whole idea of targeted therapy, and how is it different than immunotherapy?
Well, targeted therapy is specifically designed to target a specific gene change. And so most of the drugs that are currently approved for these type of changes have a very high response rate and our tumor shrinkage rate, and also have a long disease, a long time where the cancer can be controlled just on a pill. And so most of these drugs have that data behind it, and some of the drugs actually have been directly compared to chemotherapy. So we want to be able to get the best type of therapy for each patient. Now, targeted therapy is different than immunotherapy in the fact that if you aren't on the targeted therapy, the therapy doesn't continue to work. Where immunotherapy, we're trying to take the brakes off a patient's immune system in order to get the immune system to target the cancer. And in that case, if we have to stop the therapy for one reason or another, we can see prolonged immune effects where we've trained the immune system to target the cancer. Typically, interestingly, for those patients with targeted genes associated, or excuse me, changes in their genes more associated with never smoking, these patients tend to do not quite as well with immunotherapy. And so this is why, another reason why we think that these patients may not do as well, just in the fact that there's typically one or just a couple changes in their tumors where the immune system cannot target very well.
Yeah, but to build on,
sorry, go ahead, Steve.
Juliet, just to sort of build on what Juliet said, you can't guess, right? Because it's not like there's one mutation or there isn't, and we can just try a pill, because now there are so many different mutations and different pills. And if we line up that mutation, that genetic vulnerability with the right pill, we're so confident, right? We know that this is going to work. It almost always works, and it works very quickly. Patients can feel better within days, much faster than radiation, than chemotherapy. Responses are very fast and they're very frequent. But if we give the wrong targeted treatment, the chance of response is zero. It won't work. And so you can't guess. You really need to know sort of what specific mutation is there.
Yeah, as a former mentor of mine once said, test, don't guess. You've got to have, you can't give the drug unless you know the target. And as you mentioned, there's a growing list of targets that can be wedded to all these new therapies, and some of them older therapies that are still around, but certainly targeted therapies that have brisk responses. So this patient, for the sake of time, has an EGFR mutation, which is one of the more common mutations we see. This is not a gene that the patient was born with. I talk to patients about this. This is a gene only inherent in the lung cancer. People get a little confused, or patients get a little confused about genetic testing and what that means. And when we're mentioning this, we're talking about genes only inherent in the lung cancer that govern the lung cancer's growth. So this patient has an EGFR mutation. This is one of the most common genes that we see. And we see here, this is just 6 weeks of a drug called osimertinib. And we see, a lot of white on both of these lungs here. That's lung cancer that has completely resolved after 6 weeks. Is this atypical, or is this what we generally see? Stephen, is this what you're seeing in your clinic with patients with targeted therapy, these types of responses?
Yeah, it really is. We're in a specialty where you can't make promises or guarantees, but if things line up right, we're very confident where we really expect a response, not a situation where we're hoping something works. We really expect it to work. And if it doesn't work, we really are scratching our head and trying to figure out why. So seeing responses, complete responses, or even dramatic responses is fairly common. And, patients will call back and say within days, they're feeling better. And it can be very rewarding when we line it up right.
Ben, you might
Go
want
ahead.
to just note on the Guardant testing, there was data for gefitinib or erlotinib as well as afatinib, but now we have data, at least in this particular mutation, where as you chose, the osimertinib does outperform the erlotinib and the gefitinib based on clinical trial. And so, osimertinib would be our typical go-to drug right now for the first line treatment, or in patients with no prior treatment for this particular EGFR mutation.
Yeah, I think that osimertinib certainly has become the standard of care based on that phase 3 FLORA study. I'd love to spend time on the longitudinal assessment of liquid, as you see down here, but we're gonna move on because there has been some data that intuitively, if the level of the mutation in the blood drops, that's a good indicator that the drug is working very well. And we saw that in this case. I want to end this case with, unfortunately, what we know about these drugs is that they work very well for a period of time, but resistance can occur. The cancer cells can start figuring out ways to grow, and there's different ways they can do this. And we call this resistance, and that we see this, patients will start to experience more symptoms, and then we see that the cancer can grow again. And that's hard for patients. It's hard to relay that we got this great drug, but unfortunately, at some point, the cancer may start growing again on that drug. So the patient here, unfortunately, after 2 years of being on osimertinib, which is not atypical, I don't think, that's right in the range of what I generally see, does start experiencing worsening shortness of breath and some shoulder pain. And we see that there is some pleural fluid there that's built up. And to save the suspense, essentially this is tapped or removed and it's cancerous, and there's worsening cancer below that, underneath that pleural fluid. And so I guess the question is, a lot of patients ask, well, you started me on a great targeted therapy. It's worked for a while. What's next? What do we do next? And what's the plan? And so, Stephen, I know you work a lot in the genotype space. You've led a lot of the efforts in the resistance setting and identifying novel genes in lung cancer. What do you tell patients when we get, or if you get to that point?
Right. Well, I try to prepare patients early. And I'll also say there's no limit as to how long a drug like osimertinib can work. I think we've all had patients, we've shared patients that have been on for extremely long periods of time. But as you said, these aren't cures. And eventually, for most patients, we will encounter resistance. And the way I look at it, if something's changed, we gave a drug, we had a good response to the cancer, got a lot smaller, got a lot better, and now it's growing again. So something has changed here. If we haven't changed our treatment, then it means the cancer has changed in some way. If we can pinpoint exactly how the cancer has changed, then maybe we can overcome that change, adapt our treatment to really overcome and counter that resistance. So I would repeat a biopsy. I would send a liquid biopsy. I would send a tissue biopsy, and really try to understand what's different about this cancer, and can we very easily adapt our treatment to overcome that resistance.
Great points. Julie, you've been intimately involved in the immunotherapy field and led a lot of the efforts. Is this where immunotherapy comes in? Is there a time where immunotherapy comes in these patients?
Well, obviously it depends on the patient and how they're doing, but the clinical, outside of a clinical trial that matches a patient's resistance mechanism, the next standard treatment is really chemotherapy or chemotherapy plus immunotherapy. And for patients with EGFR mutations, the only study that included patients like this in chemotherapy and immunotherapy trial was a study called Empower 150. And that trial combined chemotherapy plus a something called anti-VEGF antibody, bevacizumab, or also known as Avastin, and then added atezolizumab, which is a immunotherapy drug. And that 4-drug regimen seemed to do better compared to chemotherapy plus just the bevacizumab, or better than chemotherapy itself. So in patients that I think can tolerate those 4 drugs, that's what I consider. I don't think single agent immunotherapy at this point would be the next best thing. I think really chemotherapy in some type of combination would be the best place to go outside of a clinical trial that specifically is for a mechanism of resistance that can occur.